In most patients with respiratory pathology, including those that are critically ill, a physical examination is insufficient to obtain a definitive diagnosis. The chest X-ray, even when associated with physical examination, has limited accuracy. The gold standard thoracic CT scan is not always feasible and can present numerous issues, including those related to transportation, ionizing radiation, and the limitation of resources required to transport the patient. The lung ultrasound can be performed quickly and easily in critically ill patients. It has a higher diagnostic accuracy than physical examination and chest X-ray combined. Lung ultrasound has low specificity, however, it provides high sensitivity similar to that of a chest CT scan. Easy to deploy and operate at the bedside, it provides the advantage of monitoring disease progression. It also can be used to guide fluid management, weaning, and therapeutic procedures such as thoracentesis. It is easy to learn and teach, avoids the need for transfers and the risk associated to radiations, and it is far easier to disinfect compared to a CT scan. Due to the phenomenon of acoustic impedance, the images obtained using lung ultrasound are relative to the volume of air and fluid present in the lungs. When the ultrasound hits structures with differing impedances, some are transmitted across the boundaries while others are reflected. When using lung ultrasound, it is important to comprehend the various impedance of the tissues to fully understand the image obtained. Soft tissues and air reflect 99.9%, rendering this interface visually impenetrable to ultrasound. Therefore, structures below the pleura in an air-filled lung cannot be visualized. Only artifacts will be seen. The ultrasound machines available in critical care settings are likely to have either a linear probe for vascular access, curvilinear probe for abdominal exploration, or a phased array used for echocardiogram, or a combination of them. A great advantage of lung ultrasound is that useful images can be obtained with each of these. Linear transducers are used for close examination of the pleura and its pathology. The poor penetration of high-frequency ultrasound and the narrow width of the sector results in poor images of the deeper structures. Convex transducers are the best all-round probes for lung ultrasound. As the sound is reflected back to the probe, the rib shadows will be visual. Also, the bright white pleural line about 0.5 centimeter below the rib line can be seen. Center this in your screen and you will know the ribs almost appear as the bat wings. The exploration areas must guarantee a correct evaluation of the largest number of lung areas in the shortest possible time. A comprehensive examination can be performed on supine patients. There are several systems that have been described in the literature to examine the thorax. One is a three-point examination of each lung. This is quick and simple, and there is a convincing evidence that this technique yields a high diagnostic accuracy. It is therefore an excellent starting point for a novice. However, most texts recommend 6 exploration points, as shown in the image. The probe can be positioned both longitudinally, perpendicular to the ribs, and obliquely along the intercostal spaces. For each point, the probe should be placed at 90 degrees to the skin, looking into the lung, with the left of the screen cephalate and the right coated. The normal anatomy is shown on the screen, and the impedance of the different tissues that the ultrasound passes through allows us to understand the image obtained. The air below the pleural line reflects most of the ultrasound back to the transducer. This is itself a reflector, meaning some of the ultrasound waves will bounce back and forth between the pleura and transducer, generating artifacts called A-lines. They are horizontal lines below the pleura with the same spacing as the distance between the probe and the pleural line. Because they demonstrate the presence of air below the pleura, they are present both in normal lungs and in pneumothorax. The visceral and parietal pleura are normally closely opposed with a minute amount of fluid between them and slide over one another with respiration. The appearance of this is a backwards and forwards movement of the pleura, often with little blebs appearing to move up and down the pleural line. Small artifacts, white or black lines, projecting a few millimeters below the pleural line, move with the sliding. These are more commonly seen with high-frequency probes and have no clinical significance. A-lines only demonstrate the presence of air below the pleura. They are present both in normal lungs and in pneumothorax. This pleural displacement that presents one pleura over another is known as sliding sign. An M-mode image, using a single scan line to demonstrate echoes plotted against time, with long sliding present, will show the C-short sign. Subcutaneous tissue above the pleural line generates horizontal straight lines, while there will be a sandy appearance below the pleural line created by the movement of long sliding. In a real image, we will be able to observe the long sliding and horizontal lines, A-lines, distributed equidistantly in depth. Pneumothorax is defined as the presence of air or gas in the cavity between the lungs and the chest wall, causing collapse of the lung. The features of pneumothorax are abolished sliding, absence of B-lines, and absence of lung pulse. A loss of lung sliding occurs when there is no dynamic interaction of the parietal and visceral pleura. The possible causes are summarized in the picture. When the lung sliding is absent, the M mode does not register any disturbance at the pleural line and therefore give a quiet trace. This pattern is called the barcode or stratosphere sign. In practice, lung sliding is best appreciated by careful visualization of the pleural line rather than an M mode study. The presence of any B lines means that the pleural layers are posed at that point, ruling out pneumothorax. The interface of where a healthy lung starts and where the pneumothorax ends is known as the lung point. On one side of the lung point, healthy pleura will be seen with pleural sliding, whereas on the other the pneumothorax will show a still pleural line with absent sliding. We will be able to observe the fleeting appearance of a lung pattern, lung sliding or pathologic comet tail artifacts replacing a pneumothorax pattern, absent lung sliding plus A lines at a particular location of the chest wall. The lung point can be identified as well with M mode. The features of a pneumothorax are abolished sliding, absence of B lines, absence of the lung pulse, and presence of the lung point. Air, being node dependent, will collect anteriorly in a supine patient. Placing the probe on the highest point of the anterior chest and demonstrating lung sliding will rule out a pneumothorax in only a few seconds. The presence of lung sliding, B lines, or lung pulse will rule out the diagnosis of pneumothorax. Interstitial syndrome occurs when an increase in interstitial and interceptal fluid is present. Interstitial syndrome is a sonographic entity associated to specific clinical features. However, the clinical examination and supine chest X-ray have a poor sensitivity in detecting it. The ultrasound features of interstitial syndrome are the B lines. These are artifacts generated by the juxtaposition of alveolar air and septal thickening, either from fluid or fibrosis. 3 or more B lines between two rib spaces or close together in a transverse image are pathological. They can be localized, disseminated, homogeneous, or non-homogeneous depending on the pathology. They are present in any disease affecting the interstitium. It can be present in many clinical conditions like pulmonary edema, pneumonitis, ARDS, lung fibrosis, lymphangitis, and pulmonary contusion. 3 or more B lines arising from the pleural line will be mandatory to identify an interstitial syndrome. Depending on the degree of evolution of the disease, a reduction in lung sliding can be observed. When edema becomes more severe, ground glass appearance on the CT scan, B lines become more numerous and closely spaced. Very severe edema causes them to fuse with a hyperechoic confluent pattern that fills the space between two ribs, giving the appearance of a wide lung. As the interstitial involvement progresses, a characteristic pleural thickening and irregularity occurs, as well as a reduction in lung sliding. presence of more than 3 coalesced and irregular B lines and thick pleural edges with abolitionist sliding will define a severe B pattern. The pattern of B lines and the presence or absence of pleural edges and consolidations will help to establish if the interstitial syndrome is of cardiac or pulmonary origin. Sonographic entity of alveolar syndrome encompasses alveolar consolidation and atelectasis. Consolidations are highly fluid-filled alveoli and over 95% reach the pleura, so ultrasound can image the pathology directly. When the lung is highly fluid-filled, it resembles the liver in echogenicity. Extensive consolidation will allow the opposite pleural line to be seen. Severe consolidation will often be accompanied by a pleural effusion. A fully formed consolidation appears solid, liver-like, and very often with pockets of trapped air, known as air alveologram, and highlighting air-filled bronchioles, air bronchogram. This gives rise to an air bronchogram sign that changes with respiration, called dynamic air bronchogram. Air bronchograms appear white, while fluid bronchograms appear as black. They are puntiform if transverse to the ultrasound beam and linear if longitudinal. Fluid bronchograms are specific to pneumonia. An air bronchogram, which moves with the respiration, excludes bronchial obstruction and helps to distinguish between consolidation and atelectasis. Static or no air bronchograms make atelectasis more likely. Dynamic air bronchograms make pneumonia more likely. A pleural effusion is an unusual amount of fluid around the lungs. Fluid builds up in the space between parietal and visceral pleura. A small quantity of fluid is normally spread thinly over the interpleural space and acts as a lubricant between the two membranes. Any significant increase in the quantity of pleural fluid is considered a pleural effusion. Depending on the cause, the excess fluid may be either protein poor, known as transudative pleural effusion, or protein rich, known as exudative pleural effusion. These two categories help physicians to determine the cause of the pleural effusion. A pneumothorax is an accumulation of blood within the pleural cavity. An effusion will be seen as a rectangular shape, usually anechoic, whose borders are the ribs cephalad-encoded and the parietal and visceral pleura at the top and bottom. This is known as the quad sign. It is imperative not to confuse an A line for the visceral pleura. The lung moves towards and away from the probe with respiration, which can be visualized in B mode. In M mode, the sinusoid sign is observed. In real ultrasound, we can observe a rectangular effusion with the lung moving towards and away from the transducer. B lines are common under effusion inside the pulmonary parenchyma. Pleural effusions are dependent because of gravity and therefore will appear caudate and posteriorly in critically ill patients. They are easily identified between the diaphragm and lung posterolaterally. The lung will float on top of an effusion. With the diaphragm in view, a significant effusion will be seen surrounding the basal lung and separating it from the diaphragm. Atelectasis or consolidated lung base is usually seen floating around. This movement of atelectasis lung is named the jellyfish sign. The interpretation of different patterns and artifacts obtained during lung scanning will provide an estimate of the content and balance between air and fluid. Therefore, the lung ultrasound can be considered as a real-time densitometer. The Blue protocol is a fast protocol to be performed in less than 3 minutes, which allows diagnosis of acute respiratory failure. It includes a venous analysis done in appropriate cases. Pulmonary edema, pulmonary embolism, pneumonia, COPD, asthma, and pneumothorax yield specific profiles. In a dyspneic patient, in presence of lung sliding, bilateral B pattern will probably drive our diagnosis to pulmonary edema. The presence of lung sliding and A pattern will force us to carry out a venous study. In case of thrombosed veins, there will be a high probability of having a pulmonary embolism. If there is no thrombosis with positive PLAPs, we will think of pneumonia. Without PLAPs, in asthma or COPD. With or without lung sliding, the presence of A, B, or C profiles will guide us towards a possible diagnosis of pneumonia. Abolition of lung sliding with B pattern, pneumonia, and A pattern with lung point, pneumothorax. If A pattern is observed with not lung, other diagnosis modality will be required. All findings identified in the different exploration areas must be reflected in a report sheet. This document will help future evaluations of the patient's evolution, especially when the re-evaluation is carried out by a different examiner.